Yeah, fine.
Good evening, everyone. A warm welcome to all the postgraduate students, esteemed faculty members, respected dignitaries who have joined us today to the ISA National Online PG classes. These classes are held every Monday evening at 6:30 p.m. to enhance the knowledge and skill of the young anesthesiologist. The topic of today's class is Role of Anesthesiologist as a Perioperative Physician. Has the day arrived? Myself, Dr. Sarita Sa, working as a senior resident in AIMS Bhatinda, and I have the honor of being your screen coordinator for today's session. To begin this academic session on an auspicious note, let us seek blessings of Ma Goddess Saraswati. Now, to formally commence today's session, I now invite Honorary Secretary Dr. Sukhminder Jeet Singh Bajwa sir to share a few words with us.
Thank you, Dr. Sarita. It's a very pleasant evening today. So we have got a very eminent speaker in the disguise of our own president, Dr. Balavenkat sir, and to host our immediate past president academic chair, Dr. Divetya sir. So coming to the topic, actually, this is a very wisely chosen topic. We are doing every day academics on every Monday. But the topic is aptly designated also as the day arrived, as we as a perioperative physicians. I think going forward soon, what my vision is that we may start going to have its wings expanded in the form of DM perioperative medicine in the coming days. The way we are going for a DM pain medicine at the moment. So I think that day is not far when the perioperative medicine will be a specialty where it is DM course will be commencing in our own nation. I think we may be the pioneer one in the globe also, and we will make an effort and decide in our upcoming GC meeting also to start such courses. And perioperative medicine, because we have to work little more harder. Every time we go for the pre-anesthetic checkups and the fitness, we always depend upon the physicians or some other super specialists to go for that. Yeah, super specialists sometimes we have to see because when the cases are real tough or the pathology is so much in the advanced stages, the super specialists have to be consulted. But majority of the times, I think the time will come when we have to see everything ourselves. I think this is the right step. Whether the day has arrived or not, that will be decided today after this class, where we have reached at least in the present day. And I like to request Dr. Divetya sir also to say a few words before we start with the formal class. Divetya sir.
Good evening and welcome to this very important session of the online PG classes. I think although this is not a purely academic session, I think it is one which is of great importance to our specialty. And I think it is very appropriate that Dr. Balavenkat addresses the young minds and the forthcoming the future anesthesiologists and the future leadership, about the status of anesthesiology in our country and in the rest of the world. And in many places, we are seeing this movement towards perioperative medicine. And I think Dr. Balavenkat, being the visionary leader that he is, and he's got his own thoughts, his own ideas, and it'll be really interesting to know whether we can. Of course, we should all aspire to be perioperative physicians, and maybe many of us feel we are perioperative physicians. But uh, let's see what Dr. Balavenkat has to say about the reality of the situation, what we can do, what we've achieved, and what more we need to do. And I'm sure the day is not very far when we will be recognized as perioperative physicians. Unofficially, in many places, we are the perioperative physicians. But whether, as Dr. Bajwa pointed out, whether we have a university, an MC recognized specialty, whether we have a national board specialty, I think we have. But I think that is if we have to aspire to do that, I think we've got the right leadership. We've got Dr. Balavenkat, who will not only talk to us, but I'm sure he will take this mission and vision forward. So I'm really looking forward to hear what Dr. Balavenkat has to say, and I'm sure we will enjoy the discussion that ensues after that.
Thank you, Divitya sir. I think we should proceed with the further formal proceedings. So Sarita, it's back to you. Take over the class from here.
Thank you so much, sir, for your insightful words and also for inspiring the young anesthesiologist. So before we move ahead with our academic session, I would like to invite and introduce my co-screen coordinator, Dr. Bhavani. She will now take over and introduce our distinguished speakers and moderators.
Thank you, Dr. Sarita, and good evening, everyone. I'm Dr. Bhavani, Assistant Professor Anesthesia at Government Medical College, Sangareddy. It gives me immense pleasure to welcome all of you to this special session, and I'm truly honored to introduce two of the most distinguished leaders of the ISA. First, it's my privilege to introduce Dr. Balavenkat Subramaniam, the President, ISA National. Sir is the Senior Consultant and Academic Director, Department of Perioperative, Anesthesia and Perioperative Care at Ganga Hospital and Medical Center, Coimbatore. Specialty interests include regional anesthesia and pain medicine. Sir is the Secretary, World Federation of Society of Anesthesiologists from 2024 to 26. Sir is also the National President, ISA 2024. He is the President at Academic Chair, Oceanic Society of Regional Anesthesia and Pain Medicine, Founder, President and National Chairman of AORA India, Associate Editor, Journal of Regional Anesthesia and Pain Medicine, 2019 to 2023. Sir has delivered 777 national lectures, 75 international lectures, 54 workshops in regional anesthesia, 17 orations, including the prestigious Dr. Venkatrao Memorial Oration. Invited as faculty at 7 World Congresses of Anesthesia. Sir authored 37 publications, 7 book chapters, and 1 book. He has also received multiple national and international awards. Today, we are fortunate to have Sir as a speaker for this session. Next, moderating the session, we have Dr. J.V. Divatia, the Chairman of the Academic Committee, ISA National. Sir is known for his unwavering commitment to academic excellence, and his efforts have continuously fostered learning and professional growth within our fraternity. Sir is currently the Head Critical Care at Lilavati Hospital and Research Center, Mumbai. Sir's specialty interests include critical care medicine. Sir is the Vice Chancellor, College of Indian Society of Anesthesiologists, immediate past President, Indian Society of Anesthesiologists, Editor-in-Chief, Indian Journal of Critical Care Medicine, past Editor-in-Chief, Indian Journal of Anesthesia, past President, Indian Society of Critical Care Medicine, and Sir has over 210 publications in international and national journals. Last but by no means the least, joining us as another moderator is Dr. Sukhbinder Bajwa, the dynamic Honorary Secretary, ISA National. Sir's leadership, dedication, and vision have been instrumental in advancing the goals of the ISA and strengthening its presence nationally. Sir is currently the Professor and Head Anesthesiology at Gyan Sagar Medical College, Patiala, Punjab. Sir's specialty interests include research methodology, obstetrics, neuroanesthesia, and emergency medicine. Sir has received academic appreciation from Sir R.D. Miller in 2003. Sir has authored 8 book chapters, 430 plus national and international publications, 7 national guidelines in anesthesia, medicine, endocrinology, and Sir has also edited 2 books. Sir is the Editor-in-Chief of Practical Evidence in Anesthesia Knowledge Journal, ex-Editor-in-Chief of Northern Supplement of IJA, ex-Associate Editor-in-Chief of IJA, Associate Editor-in-Chief of JOCP. Sir is also the Executive Board Member of 30 plus international and national journals. ex-Honorary Secretary of Punjab State ISA, ex-National Governing Council member of ISA. Presently, sir is the Honorary Secretary ISA National. Sir has received KPR Best Young Anesthesiologist of India in 2022. Sir has received the Best Research Paper of Indian Journal of Urology in 2013. ISA National President Appreciation Award for 2000. Has received ISA National Award for developing research methodology module in 2000. Sir has also received ISA National Award for academic in 2022. I am in my sir has been University 2020 the top 2% scientists, which is remarkable the entire community. It's truly research and specialties today. So this on extend a warm all three of you. For all the participants during the lecture, all the participants be open for any query.
Dr. Bhavani, Dr. Bhavani, your voice is breaking. So just see, don't worry, we will explain the rules to them. Everybody will be muted to the class during the entire class, and only after the end of the class, everybody will be given that liberty to speak. So we start with the, first of all, thoughts from the Balavenkat sir before he starts his own class. Over to you, Balavenkat sir.
Thank you so much for giving me an opportunity to be a part of this postgraduate session. Thank you, Dr. Sukhminderjit Singh Bajwa, Honorary Secretary, for looking forward for every Monday, all the postgraduates in this country for this ISA-sponsored academic session. Thanks for doing it religiously with all the important topics. And I'm so privileged that this session is being moderated by one of the doyens of anesthesia and critical care, who has done phenomenal contribution in the field of perioperative care, especially the onco-anesthesia and critical care, Dr. Jiggy Dibatia sir. So it's my privilege that my immediate past president and the honorary secretary are moderating the session. And every medical specialty has a fabric. The neurosurgeons, the orthopedic surgeons, the cardiologists, the cardiothoracic surgeons, everyone is supposed to have a fabric. And the anesthesiologists also are supposed to have a fabric. And it's important that this fabric has to be dyed, made shining, and it has to glitter. And if that fabric has to glitter, the only way forward is to make sure that all the work that you do is recognized and the whole world knows the importance of our specialty. And there has been a paradigm shift in which the anesthesia is being practiced in this world, thanks to the advent of technique and technology and adoption of this by the anesthesiologist. So no more we are confined to the four walls of the operating room, and the whole world is looking forward for us to take up the mantle of leadership in perioperative care. So with this introduction, I would like to embark on my journey into the presentation. Before that, are there any more formal sessions, Dr. Bajwa?
Yes, sir. You can start with the proceedings.
Yeah, thank you. Are my slides visible?
Yeah, very much visible, sir.
And audio is okay?
Fine. Everything's fine, sir.
Yeah. So thank you so much for both the moderators, and thank you so much for Dr. Sarita and Dr. Bhavani for being a part of this session and being the screen coordinators and manager. Good evening to everyone. I bring to you greetings from the city of Coimbatore, and Adiyogi has become an inherent component of everyone visiting the city of Coimbatore, the largest human bust on earth, which signifies the importance of yoga in day-to-day life. In fact, if all our patients and all of us continue to do yoga, the perioperative care of every surgical patient would become very simple because the organ reserves will enhance considerably. I would wanted all the postgraduates who are here to make sure that every day they read this particular wording. When we are born, we are all born as equals. But human glory lies in ensuring that we do not die as equals. I think this is something which all of us have to tell ourselves every day. And I welcome all the postgraduates for this evening session. And I have yet another important note which has become a part of every presentation of mine of Mahatriyara. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. And if we need to do that, it's very, very crucial and important for us to understand all this can be accomplished by managing our time appropriately. At a point of time we reach in life, the time becomes our God. Those who utilize it appropriately are the most successful professionals, and those who keep saying that they don't have time are those who can never climb up the ladder. So it becomes important that each one of us as an anesthesiologist have to set our core values appropriately, because all of us want to be successful. And success is all about being in the process of joyfully creating a life that reflects your highest values, your deepest beliefs, and your greatest dreams. And every postgraduate attending this session should make their mind that they need to be one of the most successful, legendary professionals, whichever part of the world they are practicing. And for that, they need to have deep belief in themselves that they will accomplish, and they have to dream great things and aim very, very high. This is one of my very, very favorite slides. I would like to congratulate all of you who are present here who decided to be an anesthesiologist. And according to me, anesthesiology is the mother of modern medicine. Why? I think this is the only specialty, if you see the curriculum, the only specialty which reads about premature children, neonate, pediatrics, and geriatrics. It reads about all the comorbid conditions known to mankind, both congenital and acquired. Reads extensively about pharmacology and the pharmacogenetics, pharmacovigilance, because we deal with several of the drugs. We are the only specialty which read about all the other specialization. You name it, we read it. Pulmonology, cardiology, hepatology, gastroenterology, obstetrics and gynecology, psychiatry, everything that you read. And all that is needed as far as medicine is concerned. Our textbooks are similar to the textbooks what MD General Medicine they read. We read about surgery, all kinds of surgery, because we need to know what does it mean by a posterior fossa tumor if it's a neurosurgery, and what it means if it's a congenital heart disease, what it means when a patient is on an ECMO. So tell me any other specialization known to mankind which reads so extensively like what an anesthesiologist reads. And hence, I would call anesthesiology as the mother of modern medicine, and all of you should be proud of being an anesthesiologist. And I consider anesthesiologists are truly the special children of God. The reason God created pain and created anesthesiologists to alleviate pain. And we are the true angels because every single surgical patient who comes to undergo a surgery in a hospital, when you ask them a question, what is their biggest concern? They want to live through the surgery. They said they wanted to be alive after the surgery and they wanted to be pain-free because of the surgery. These are the two pertinent points that they share with us, and more important than the outcome of the surgery. So both of this is done by anesthesiologists, and hence I call them the angels. When a code blue is announced inside a hospital, when there is a critically ill patient, when there was COVID which struck us, the presence of or absence of an anesthesiologist inside an institution decided whether this patient is going to live or die. So all the critically ill patients, patients who are near death, if they have to live, they need to have the expertise and the skill of the anesthesiologist. May it be to start a rapid intubation, may it be to start a venous access to hydrate the patient and increase the tissue oxygenation. All that is needed to make somebody live is possessed by an anesthesiologist, and that's why I would consider it as a sacred branch known to mankind. The mother of medicine, the true angels, and the sacred branch. And I'm very happy that the Indian Society of Anesthesiologists is doing extremely well in making sure that our professional organization scales up not only within the country and outside the country. And in the last general body meeting at Patna, thanks to the governing council, all the past president, all the members of the National Executive Committee, all the senior leaders of Indian Society of Anesthesiologists for making us the fourth largest society in the World Federation of Society of Anesthesiologists. I think as a president of the Indian Society of Anesthesiology, it is important, as the secretary and the immediate past president is here, we wanted to percolate this message to every single postgraduate who is attending the session that we have become the fourth largest society in the world, next to United States, China, Germany, and it's India. So this is an endeavor, not only in terms of numbers, but we wanted to make sure that we scale great heights in all aspects, what is needed of this fraternity. We have several initiatives that have been undertaken by the national body, and we have made it academic with the start of College of Indian Society of Anesthesiology, which will focus on guidelines, advocacy, new programs, new teachings, new fellowships. And I also take this opportunity to urge all the postgraduates who are attending the session to be a part of the ISA Inland Fellowship. So in the next conference in Raipur, please take physically an examination, and the top 25 students will be given the fellowship grant by the national body Indian Society of Anesthesiologists. So you can visit centers of excellence across India and be mentored by some of the top names of this country. And I think this is very, very crucial in your journey of becoming a true professional. And you can choose an institution based upon where your liking is. It can be a cardiac center, it could be a neuro center, it could be a transplant center, a regional center, trauma center. So 25 centers have come forward, and I would urge all the postgraduates who are here and all those who will probably hear it in the YouTube later to be a part of the ISA Inland Fellowship examination, which will be conducted in our next national conference in Raipur. And then you will be given a grant, and within the next 6 months, you will undergo this 1-week training in another different center, and it's an excellent program. We plan to extend this for international fellowships in the coming days. And I'm also very happy to share that ISA has signed a memorandum of understanding with American Society of Anesthesia and American Society of Enhanced Recovery and the European Society of Anesthesia and Intensive Care. It's in the offing. And all this, I wanted this rich benefits to go on to the entire postgraduates. And for this, I would request all of you to make sure that you are an associate life member of Indian Society of Anesthesiologists. And the minute you finish, you join the ISA as a life member and strengthen ISA and take ISA much forward nationally and internationally. And also take this opportunity to welcome you all as the current Secretary of the World Federation of Society of Anesthesiologists to the next World Congress of Anesthesia in 2026. I just wanted to take a minute. I wanted to welcome you all to the National Conference in Raipur between the 26th and 30th November 2025. There is a lot of relevance to the topic of today and this Congress. 17 workshops being done by the best names in the country. And this is the first ever time there will be two directors, one from the ISA and one from the specialty. Every workshop is being directed by some of the best names in this country. And in the course of this talk, you will understand why it is important to attend workshops, why it is important to attend a master class, and why it is important to network with international faculty. We have 20 plus international faculty, including the president of the World Federation of Society of Anesthesiologists, and be a part of the winning team. Learn to be a winner by presenting your work, winning the awards, and enriching your CV as you grow up the ladder. A minute about the World Federation of Society of Anesthesiologists. It's the largest global professional membership organization for anesthesiologists, and it has got 141 member societies from 150 countries. And WFSA represents anesthesiologists all around the world, including the Indian Society of Anesthesiologists. And the value of the federation is it wants universal access to safe anesthesia and to unite and empower anesthesiologists around the world to improve patient care. And this is the next World Congress of Anesthesia. Please note down and please be a part of the journey as a young anesthesiologist. The minute you finish the post-graduation, or even if not, try to embark on the journey to give an international presentation in the next World Congress between 15th and 19th April in Morocco, Marrakesh. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. I've been working here for the last three decades. This is my 30th year. I joined here way back in 1995. It's a 680-bedded tertiary care referral center with 38 operating theaters, 96 anesthesiologists, and most importantly, the last 2 decades, we have worked as perioperative physicians. We have weaned off all the physicians from the hospital. Having said this, like Dr. Bajwa said, we also have a panel of super specialists to help us in situations where we cannot handle. But believe me, 90% of the perioperative issues can be handled by us meticulously with good results, and maybe 5 to 10% we will need accessory help. What has been the advantage of doing this? The advantage of doing this, we have become better because whenever we are challenged, you try to learn a new skill, you try to accomplish by reading more about it. So your knowledge and skill keep increasing when you keep challenging. And you also make sure that when you do this, the surgical colleagues have tremendous confidence in the whole system because you made sure that the pre, intra, and post-op care have been taken care of very, very effectively. So we have been doing it for the last 20 years. And when we discussed to have a topic, I thought I will speak on a topic based upon the hardships and the journey that we had. And the day has arrived for almost every institution in this country where anesthesiologists could serve as perioperative physicians. And this is my email ID. Any postgraduate has got any concerns and query about this topic can write to me anytime on the probable possible obstacles that they can or probably they may face in their journey in becoming perioperative physicians. It is not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. I think this is a very, very profound statement. And I think it's very, very important for each one of us to make sure that we become better every passing day and we adorn the mantle of being a perioperative physician. For example, this was India when we got independence. Exactly in 1947, we looked like this. This was the mode of transportation. But the country decided to change. The country never wanted to be like this. And what happened now? It's a revolution. And India has got the second largest highway network in the world, the largest sea link in the world. The modern downtowns look like this, and we put Chandrayaan on the moon because India decided to move forward. India did not say, I did this for the last 30 years, so I will continue to be the same. And similarly, I think it is important for every single anesthesiologist who is attending this session to say yes to the new innovation, which will accentuate patient safety. And I wanted you to understand there are few things which is revolutionizing anesthesia practice, which is moving toward taking us towards being a perioperative physician. And number one, the tool on the left, the ultrasound. The ultrasound has become the modern day stethoscope, and this single instrument is going to make the difference between a normal, mediocre anesthesiologist to one of the most reputed anesthesiologists. By knowing to use this particular tool, you're going to save several lives. So the point of care ultrasound, which is used in bedside, in critical care, and in the perioperative period, has revolutionized. If you have an hypoxia, it's enough to have this machine to see whether it's a pneumothorax, whether it's a pulmonary edema, whether it's a pulmonary cause, or whether it's a cardiac cause, within seconds, before the arrival of the pulmonologist, before the arrival of a cardiologist, an anesthesiologist in the bedside can decipher the cause of hypoxia. If there is hypotension, you will just see the IVC, you will see the heart, and you will exactly know whether he needs more fluids or whether he needs inotropes or whether he needs vasopressors. So this particular tool should be what every single postgraduate should work on, both in point of care ultrasound as well as its utility in other aspects, including nerve block, having an excellent venous access, putting intra-arterial lines. So this is pushing you towards becoming a phenomenal perioperative physician. And when you want to become a perioperative physician, you need to be masters of the developments in the intraoperative period. And one of the things which all of you should embark on is target controlled infusion, the TCI. And different formulas have arrived, 16 formulas, many machines commercially available in India at a cost of 1.5 lakhs. This is going to revolutionize the way you do intraoperative cases. And you should embark on the journey of becoming a specialist in using target controlled infusion. And what you see here on the right is the workstation, the modern day workstation, and you need to be an excellent interpreter of what is happening to the flow volume loop. And now we are moving forwards, like, for example, what you see down is the MEP SSCP monitoring in a spine surgery, subcortical monitoring happens in neurosurgery. So I would urge all the postgraduates here to embark on the journey, to find out what they have a gap, to see how can they upscale the skill and make sure all this become your inherent skill sets, and you will going to progress profoundly because of this. And if it has to happen, then it becomes you need to embark on the journey to learn from the best. And that's why I said you need to come to Raipur, because we have carefully crafted it in such a way that all this is incorporated in our scientific content. This is an article I wrote, editorial I wrote as anesthesiologist, as a perioperative physician, based upon our what we faced and the challenges that we had in our hospital. But I just wanted to tell each of you, our workplace is our prayer. Everything that we experience, from the food to the cloth to the shelter, the comforts and the luxuries that we enjoy, are all the rewards from the work we do. So we need to revere our workplace, and our workplace should become our prayer. And we need to become a power to reckon within this institution. And for that, I wanted each one of you to invest every second of your time to become extremely knowledgeable and do all that is needed to learn skill. Even if your duty finishes, if it means that you need to go to the emergency to learn a new technique, a technology, a procedure, please do it. When you are a postgraduate, the more you learn, the more skill you become, and that's going to help you lifelong. So knowledge and skill, if you have together, will result in excellent clinical outcome, and you will earn respect. And you need to regularly read and update. And it's important the third year becomes the true teacher for the second year, and the second year the true teacher for the first year postgraduate. So keep on learning and keep on sharing the knowledge with your juniors, and you would truly become a role model. And in this journey, in this process, I wanted you to enter into audits of your work, clinical research, and adopt evidence-based practices. For this, you need to read the journals. And believe me, this combination will result in you climbing great heights as a perioperative physician, because simple things like postoperative nausea, vomiting, if you start reading, then you will know which is the right combination of drug to use in preventing postoperative nausea, vomiting. The shivering, which is the best drug to use in shivering. For all this, you need to read, you need to see the latest update, you need to see the new drugs, you have to see the new drugs that have come into the market. So I think in the process of becoming a perioperative physician, to enhance your confidence to encounter every single problem that your patient poses to you, you need to become extremely knowledgeable. So please be a part of the journals, apart from your reading the theory, and also make it a point, like the Inland Fellowship, even if you have completed your post-graduation, please do fellowships for 1 or 2 years by visiting centers of excellence, or even otherwise small and short visits to centers of excellence and observe them and their practices, and at least once in 2 years to attend an international meeting. To become a perioperative physician, it's very crucial to have excellent self-discipline, and most importantly, you need to sleep the day uh, prior to you doing a major procedures. It is said that the split-second decisions have to be taken in anesthesiology, especially when you do critically ill patients. And for that, you need to have self-discipline of sleeping adequately to make yourself as competent as it could be. It's like a army jawan in the frontier, in the front facing an enemy, where every second counts and 1 microsecond is enough to make the difference. And along with this, if you have excellent personal traits of integrity, excellent vision, and humility, you are going to exceed your own expectations. And an ideal anesthesiologist should arrive into the operating room 15 minutes early. He should be calm and unperturbed, present physically and mentally, in comfortable scrubs, and put the mobile phone in silent mode. And this is an excellent statement which I wanted to share with all of you. You need to begin with end in mind. For example, if you're going to do a major surgical procedure, its preoperative assessment has to be done prior, and there you start dreaming about doing the case, where I'm going to start the IV axis, what endotracheal tube I'm going to use in this patient. Is it flexometallic? Is it a cuff tube? And what kind of monitoring that I'm going to do? So you do the case mentally the day prior, because of your excellent preoperative evaluation and optimization of the patient. So if you start doing that, the next day when you go to the operating room, every case will become a simple case. All the peak performers, they live it, feel it, and experience it. They have played their opponent several times before they come and actually play them. And that's why they've been champions. And if you want to be a champion perioperative physician, do the excellent preoperative evaluation, make a clear strategic planning, and the net effect will be you will be able to provide quality anesthesia. And quality anesthesia has been defined by 6 domains. It should be very effective, equitable, timely, efficient, safe, and patient-centered. And this I spoke about my institution. And the way we embarked into the journey was first in treating polytrauma patients. And that's how we started, from just being an anesthesiologist inside the OR to spreading our wings into the perioperative. So we became the persons who started receiving it. See, this I put it, this is 2006 picture. This is one of the first cases which everything was done by an anesthesiologist. The resuscitation, the EFAST, and she had a splenic rupture, and she underwent a resuscitative laparotomy, a fourth-year engineering college student, within seconds of arrival, where she was close to jaw breathing, and from there onwards resuscitating her, and she's living today, she's married, she's with children. And all this was possible because the anesthesiologist worked as a perioperative physician right from the resuscitation to doing the EFAST, not waiting for the radiologist to come to do the EFAST. So this is an example of what it means to learn the new technique and what it means to implement it in your clinical practice, what it means in terms of a quantum change in a life that is going to live because of you becoming a perioperative physician. And same thing, if I look back, if we have not done this, if we had waited for the radiologist to come, and if we had waited for the other consultants to come, because she was profusely bleeding internally, she wouldn't be alive. So all this confidence comes by doing more and more and by upscaling our skills. So it's become our philosophy here that since it started working well, every single resuscitation is being done by the anesthesiologist, and all that like point of care ultrasound is being done by anesthesiologist in the immediately on arrival. And we extended this to on arrival block. This picture, I've showed it several times, but this is one of our prize pictures where even when we didn't have an ultrasound, we did this block on arrival. Since then, it has become a component. Preoperative on arrival block has become an inherent component of every single surgical trauma patients that they come to us. These two things, resuscitation of a polytrauma, on arrival block, was the beginning of our journey to become perioperative physician. And from there, we gained courage and we started doing several things. Like this is again one of our earliest cases. A 42-year-old male, fracture dislocation angle with an open wound, systemic hypertension, diabetes, very obese, coronary artery disease, triple vessel disease, was advised coronary artery bypass grafting almost 2 years before this injury. He was non-compliant. He was on a medical management. He was also taking clopidogrel and aspirin. He was full stomach. He had his lunch and he fell down in his restroom and had this fracture dislocation ankle. On arrival, his blood pressure was 220 by 120. Random blood sugar was 324. Heart rate was 124. Ejection fraction was 42%. If I was not an perioperative physician, if I didn't have the confidence, I would have asked for a diabetic opinion, an endocrine opinion, a cardiologist opinion, a physician opinion, because EF was 42%, coronary artery disease, and this would have thrown a definitive challenge. But what I wanted to share with you, because you started doing things outside your comfort zone, and since the surgeons thought that your team has become competent, slowly, you get them addicted to you. And this particular case, we spoke to the patient, the attendant, and got a written informed consent, and no consultation was obtained. After written informed consent, all that we did was a popliteal sciatic block because patient was on clopidogrel and aspirin, and it was a fracture dislocation ankle with an open wound. So believe me, after this, 20 minutes after that, the BP became 140/80. This is a case which I've told 100 times in 100 places to emphasize that anesthesiologists can do miracles, and can they do the difference, and they will do what it needs to be done in that scenario. And that's why I kind of, I've been telling that it's the mother of modern medicine. We are the true angels. Just imagine if I cast for a cardiology opinion, he would have given amlodipine, telmisartan, or whatever. But do you think the pressures would have come down by? So when anesthesiologists start working as a perioperative physician and gain the confidence, so this pressures came to 140/80, the heart rate came to 84 per minute, and the surgeon went ahead and did a debridement, close reduction. There was a lot of swelling, so limb elevation, and was taken for surgery. Almost 3 days later, again it was done under a regional block. This is just an example to tell us the power of being a perioperative physician and making the system understand that you will deliver and you will be capable of doing it. And also just wanted to run through this to make it more argue more why we should be the perioperative physicians. As I told, that we are the mother of modern medicine and we are involved in all this. And more importantly, here anesthesiologists have become the most important people in end-stage organ disorder, liver transplant, cardiac transplant, renal transplants. So when an organ is completely deranged, an anesthesiologist is able to give an anesthesia and look after them in the critical care. And why should we worry about a small rise in creatinine or a small rise in bilirubin? And throughout the world, if you see the largest numbers of fluid therapy, parenteral nutrition, blood component therapy, all is being administered by anesthesiologists. And we are excellent in invasive monitoring. We assess the internal milieu dynamically. And with the advent of ultrasound, as I said, echo, e-fast, airway ultrasound, gastric and ultrasound has become inherent component. And majority of the youngsters have embarked onto the journey of learning all this. And we become also masters in all the other aspects like bispectral index, in the ABG interpretation, thromboelastography, looking after the patients in acute pain clinic, acute pain therapy, chronic pain clinics, and chronic pain therapy. So if you now look at it, which other specialization can do all this in the perioperative period for a surgical patient? None other than anesthesiologist. And I think I urge that since we possess all this, we need to take leadership position. When we own the responsibility, it is the best outcome. When there is one leader, then there is no chaos. But when there are more than one, then it becomes a big tussle. The pulmonologist writing one order, cardiologist writing an order, gastroenterologist writing an order. So slowly we need to embark on a journey where the specialist will come and possibly give an opinion, even if you're working in a multi-speciality hospital, but leave the decision to anesthesiologists to do what they do. This may look difficult, but it is not impossible because we achieved it. If anesthesiologists have to, unfortunately, we lost Ronald Miller few days ago, but he will be remembered forever for his phenomenal contributions. And in fact, American Society of Anesthesiology asked him to identify what should be done to make anesthesiology be the best specialty in United States. And he said that we need to diversify the practice paradigm. And he said to do that and to be an important leader in medicine, you need to become perioperative physician. But in the process of doing it, everybody will ask, what is the legal concerns? Are you eligible to do it? And that's why it's very important in our institution, when we are doing this, we get a written informed consent and you directly get involved, not through the surgeon, you directly get involved with the patient and the patient attendant, explaining to them all the possible consequences that can happen and the current scenario of the patient, and take an informed consent. Believe me that in this 23 years of us being a perioperative physician, we have never had a single legal case against anesthesiologist for providing care that was needed for the patient. And in this process, when you become perioperative physician, you also embark on the journey because you see sepsis. You treat sepsis. You see what happened to your patient who came in ASA grade 1 getting into sepsis. You see urosepsis. Then you understand it is because of the catheterization. And hence, when you start becoming the perioperative physician, you start becoming so good in so many other aspects related in good outcomes, including proper hand hygiene. And then we go for, in our institution, we go for an antiseptic shower for all elective procedure the day prior to decrease the bioburden. And these points I'm adding because when one person is looking at the entire pre-op, intra-op, and post-op, they're able to pick up all the issues. I will tell yet another simple example. In our total knee replacement, our tourniquet time is 30 minutes. They do very fast. But in spite of that, I embarked into the journey of going for the best practices. I do the case under combined spinal epidural, and I give very low volume spinal because predominantly total knee replacement is for geriatric age group, and the amount of local anesthetic that they need is very less. If I don't do this, if I just put only spinal, because I say that this case will take only this much time, and it's only 30 minutes tourniquet and totally 1 hour, I end up giving a large volume of spinal drug. So what happens is it results in a precipitous fall, hypotension, so fluids, vasopressors, and so you give sometimes atropine, glycopyrrolate because there was a bradycardia and hypotension, and we have made a complete mess of the internal milieu. So the rate pressure product increased, and you decrease the diastolic time. So you're pushing in the case into having a perioperative myocardial ischemia. And in the process, you give lot of fluids, the bladder enlarged, and need to catheterization. A bladder catheterization can produce a bacteremia, and in a total knee replacement, the bacteremia can produce vegetations in the implant that has been produced. So now, all this because you have been following this patient in the postoperative period, and hence we embarked into the journey to prevent this. So we gave low-dose spinal, and if needed, after 45 minutes, a epidural top-up just to give that surgical anesthesia, so that hardly you give fluids, you maintain the mean arterial pressure, so you do not give any kind of vasopressor, atropine, and glycopyrrolate. So you make sure that you did not produce any complication because of your technique and the technology that you use. This is a single point message that I would wanted to convey. The advantage of becoming a perioperative physician is you learn from your own mistakes and you start improvising on that, and make sure that you will prevent from this happening by changing your practices to the best possible practices. So quickly to go through, there are 4 phases of care, and I consider preoperative history as the most important one. I urge all the postgraduates, please make sure that you go and see all the patients that you're going to anesthetize the next day, even if your system does not warrant it to do it today. Please make it a habit. Believe me, this is one single step forward in you becoming an excellent anesthesiologist and not a mediocre anesthesiologist. And very careful listening, every symptom accounted, and you build the plan there itself. And when you do this, when you do an immaculate examination, you assure privacy, you focus on the cardiorespiratory system. Just one test, breath holding time, and if it's more than 25 to 30 seconds, you are sure that this reserve is excellent. And the respiratory rate, no accessory muscles working, normal pulse rate, no orthostatic hypertension, a look at the airway, the spine, whole focus on this when you do it. And this one thing has become very inherent now in every center. And I would wanted possibly every postgraduate to buy a pocket pulse oximeter like a stethoscope and keep it in your pocket. It's because in COVID, we got several of them very cheap. Let it be a part of your armamentarium. And when you go and see the patient in the ward, just put this pulse oximeter and you will understand, you will pick up so many cases of subclinical hypoxemia. Many cases of subclinical fat embolism has been possible. We picked up because of doing this. So this is another take-home message that I wanted to give. And this is just the breath holding time. And all this happens when you start religiously doing your preoperative evaluation, and you can kind of, without modern gadgets, you can assess on the bedside the right vein to start, and also focus a lot on the investigations, because when you become the perioperative physician, when you want the responsibility, you want to make sure that you went through every single investigation that has been done. And for example, you see whether the renal parameters are normal. So urea is normal, creatinine is normal, but patient has been a diabetic for a long time, and HbA1c is 9.4. So immediately, now next thing you look at is, you look at the urine routine and see if there is urine albumin 1+. If it is 1+, then you know that the nephropathy has already started. Though the urea creatinine is normal, because the nephropathy has set in, you will avoid giving a non-steroidal anti-inflammatory drug. You will avoid pushing this patient into acute renal shutdown. And all this is again possible because of the fact that you're focusing on every single aspect and following this patient in the post-operative period. And um, as I said, it becomes very, very important to understand that above the age of 40 years, every year a patient is living, he loses 1% of his organ reserves of the body every year that passes by. So at the 80th year, that 40 years after 40, so 40% of his kidney is not working, 40% of his lung is not working, 40% of his liver is not working, to be taken into consideration. And on top of it, if they have comorbidities, the reserves become much, much less. And when you start doing this evaluation, then slowly what happens is, now you put them on incentive spirometry. And if they are smoking, you put them on nebulization, you put them on nicotine patch. And if they're alcoholic, you put on thiamine supplementation. And when you think that the intraoperative blood loss will be more, then when the preoperative hemoglobin is all right, now you start thinking about autologous pre-donation. So you avoid giving blood from other patient and the consequences of that. And if it's polycythemia, then you decide to do a therapeutic phlebotomy. So there are phenomenal things that happen to you when you become a perioperative physician. And now the modern day is multimode. Then slowly you embark on the journey. After tasting all this, when everybody likes the way you have become a good preoperative physician, you enter into the multimodal rehabilitation. Now you start discussing with your physiotherapist, you start discussing with your dietitian, you start discussing with your social worker, and you interact with them and tell them that this patient needs this much of protein and this much. So slowly and steadily, we are spreading our wings and learning more. And so this careful preoperative preparation and optimization takes you one level higher than normal. And I just wanted each one of you to experience it in your postgraduate days. And then when they come to the operating room, and the second look is very, very important. And here again, as I said, every skill set that will make you better. Now, just put your ultrasound on the abdomen and see what's the gastric volume. Even if in an emergency, if it's full stomach, nowadays, I think with the point of care ultrasound, you just put that, understand, and then you confidently say, there's nothing in the stomach, we can go ahead. And there's no need to rush. There's no need for a rapid intubation. There's no need to break the teeth. And all this because you upscaled your skill levels. And also when you have no venous access, then within seconds you can start when you know how to do an ultrasound guided venous placement. And there are so many gadgets which are available, the PICC lines, the mini mid lines, and all this, the new venous systems which have come in is very, very handy and helpful. And also as you become more and more vigilant, you also have certain excellent checklist that is kept inside the operating room. And again, all the difficult things become easy, and you become masters in percutaneous tracheostomy, in cricothyroidotomy. You start using video laryngoscope. And not to make mistake, WHO checklist should be a part of each of the patient that you're anesthetizing. And there are several points to ponder to make sure that intraoperative period is safe. And most important thing is when you hand over a patient and go to the coffee break or lunch room, these are the times when things go wrong. And in the process of our audits, we have found out intraoperative issues can be minimized by an excellent handing over. And also every crucial step of surgery, you should know what is next, and you need to preempt a possible complication. For example, a bone cement, the orthopedic unit, they are mixing the bone cement, and now your mind says that now there is a possibility of hypotension, there is going to be a possibility of fallen SVR, and now you're ready, loaded, and before it happens, you have preempted it and you have prevented it, a complication happening. And also when you know this, you will also call for help from a senior. And also you need to be very religious intraoperatively that mixing of drugs should not happen. Adding several drugs to the infusions, please avoid all that. It can produce so much of confusion and medication error. And every day make it a point to check your defibrillator yourself. Then you become a master of how to check the emergency drug trolley, the airway trolley, the suction, and all this will enhance your visibility, decrease your complication intraoperatively, and make your postoperative period very, very comfortable. So then you make protocols for every single case. It's procedure-specific protocols are the rule of the day. And I wanted all the postgraduates to embark on the journey on procedure-specific protocol. And one of the things which the young postgraduate should know is, quickly I will run through this in the next few slides. This is 110 years old coming for a hip fracture. He could see well, he could listen to you well, he could communicate to you, he was eating normally, he was mobilizing in his house. So this is a common scenario now. So we have created a pathway. So when a geriatric patient comes in, what do you do in the first 3 hours? They come, the x-rays are done, they're seen by an anesthesiologist, we do an on-arrival block. And even on-arrival block, we have decided, based upon the fracture site, we decided which block to choose, what drug to choose, how much to give. So if it's neck of femur, what it is. If it is trochanter with subtrochanteric extension, what it is. So everything is defined. And if there was a loss of consciousness after the fall, then you think of CT scan. If there was a loss of consciousness before the fall, now go for the root cause analysis. And all this, again and again, I'm telling you, emphasizes on enhancing your thought processes when you see a patient, and you do an excellent preoperative assessment. In geriatric age group, 2 things are very, very important for anesthesiologists. One is Parkinsonism and the other was COPD. Other things I described to you, but Parkinsonism is a simple disorder, but nil per mouth, if an order is given and one dose they skip, they become so rigid and they regurgitate and aspirate. And we have lost lives because of this few years ago, few decades ago. And since then, as a perioperative physician, you start focusing on such small things that you pick up in the preoperative, and you say that at no point of time this anti-Parkinson medicine should be stopped. And in cerebrovascular, no point of time aspirin should be stopped in a patient who has got CVA. So all this goes on to make you an excellent anesthesiology with excellent results. And I spoke about the thiamine, nicotine, etc. And also it's important that constipation, the commonest cause of postoperative myocardial ischemia in patients who have constipated and who also have coronary artery disease. Having coronary artery disease, important cause of postoperative MI has been constipation, because they try to strain at the stools, rate pressure products goes high, BP shoots up, and they have perioperative myocardial ischemia. So this is such a small thing, but you need to have elicited constipation history and put them on laxatives. So you look at all the relevant biochemical parameters, and serum albumin is supposed to be one important component now, that it determines the outcome, because the proteins are important. It shows the nutrition component. And in a large number of population in geriatrics in our hospital, we see hyponatremia. And in hip fractures, we give the block, and also we initiate multimodal analgesia. We decided what we do in the first 3 hours. We decided what we do in the next 3 to 24 hours. Then the clinical pathway once posted for surgery. Then what do you do on arrival to the operating room? What are the medications that you give? Because you 0-hour medication includes cefuroxime and antibiotics. Surgical site infection is common in geriatrics. So make it a point to make sure that this drug is given inside much before the incision is made, 30 minutes to 1 hour before. We wanted to decrease the blood loss, so we put antifibrinolytic tranexamic acid. We wanted to preempt to analgesia, so we put paracetamol, we put ketorolac. We want to prevent postoperative nausea, vomiting, so we put dexamethasone, ramosetron. And we wanted to prevent gastritis, so we put pantoprazole. And in patients who are very anxious, you put on conscious sedation, and one of the drug of choice is dexmedetomidine. So everything is defined. Everything is defined based upon the possible complication that can happen, and all that you visualize because you have seen the complication and you know you want to prevent the complication. And as I said, this 110 years old, we gave 0.6 ml bupivacaine intrathecally to make sure the mean arterial pressure is maintained. And as I said, blood conservation strategies you use, like giving tranexamic acid, keeping the MAP not too high. And when you decide to transfuse, you have to go for leukodepleted Paxil, otherwise it will produce a hypothermic reaction. Excellent temperature conservation by intraoperative warming devices and online fluid warming. And as I said about the bone marrow implantation syndrome, you need to keep an eye on that. And then once this is done, you follow this patient post-operatively, and first 24 hours, we have a specific set of patients who remain in the HDU. And if you're going to send them from the HDU, the next 48 hours, they are on the new equipment called DOSI. I want all the postgraduates to read about DOSI. DOSI is an early warning sign monitor which alerts the physician by a technique which was invented by IIT Delhi. And please go to the website and see DOZEE. It's an excellent addition for us as we serve as a perioperative physician. So you move into post-operative period. The first thing is pain. We need to keep the VAS score less than 3. We need it preventing deep vein thrombosis, so go for mechanoprophylaxis, chemoprophylaxis. Hypoxemia is the very common thing. And now you start analyzing by yourself and start treating hypoxemia. You go for early mobilization, you go for psychological support, look after the bowel bladder, look at the antibiotic stewardship and perioperative antibiotic protocols, and make sure that you have been a part of the journey on receiving this patient, making him pain-free, correcting his internal milieu, talking to the attenders, getting the informed consent, participating in the discussion with the surgeon, understanding what type of surgery, deciding the plan of action, deciding a procedure which will produce least interference into his internal milieu, make sure that his mean arterial pressure is maintained, make sure you have blood conservation strategies, make sure that he's not hypothermic, he gets a leukodepleted blood. At every given point, every single complication can be prevented by proactively deciding what you need to do, and closely follow them post-operatively and make sure that they go home. This is absolutely an amazing feeling when a patient is under complete control of anesthesiologist and you get additional help when it is needed. And when you graduate to that level of competency, the system accommodates you. They say for every single problem, they say call the anesthesiologist. Electrolyte imbalance, call anesthesiologist. Lactic acidosis, call anesthesiologist. Your reputation inside the hospital is so high that the surgeon says call the anesthesiologist, and the anesthesiologist will decide whether he wants additional help in calling any other specialist. So be a part of this journey and enjoy the fruits of being a perioperative physician. And I'll finish very soon. You learn a lot. For example, this case had a seizure. 72 years old, patient, total knee replacement done. He was only hypertensive, no comorbidities. Code blue announced. Anesthetist went to the ward, rushed him to the HDU, and on arrival we saw that the only thing that was noticed was hyponatremia, 111, and seizures. Now, had we not been perioperative physician, we wouldn't have embarked on a journey to do like this. So the new guideline of treating hyponatremia when it is acute symptomatic hyponatremia is completely different. I wanted all the postgraduates to please go and read how to treat acute symptomatic hyponatremia, and you will see such excellent results. So here you promptly infuse 150 ml of 3% hypertonic saline over 20 minutes. Again, I'm saying, please go and read. Please go and discuss with your professors and assistant professors before you embark on the journey, because from time immemorial, we were thinking about central pontine myelinolysis when we gave hypertonic saline fast. But this is just an example of how when you start thinking about several things other than just spinal epidural or intubation, how good our thought processes become. And here was another patient, 68 years old, and severe headache on day 2 after undergoing a TKR. And contrary to what we thought, this was the first case that in my whole life that I saw a purulent meningitis happening secondary to our intervention. Since then, we have become so rigid in the sterility protocols of anybody giving spinal anesthesia. Again, because you have to deal with this complication inside the hospital. If it was headache, it was not neurologist who was called, it was the anesthesiologist who was called. And anesthesiologists are the only one who know what happened inside the theater, whether documented or not documented, and who could relate to that particular complication happening in the post-operative period. So this I spoke about Parkinsonism. And as I said, after we put pulse oximeters in the ward everywhere, we detected a lot of fat embolism syndrome. And in rounds, this is one thing which you know that it is rhabdomyolysis and the fluid intake is not adequate, and you anesthetists detect abdomen compartment syndrome requesting decompressive laparotomy. All this has been possible because we embark on the journey to think on 360 degrees, learn more, get depressed because you don't know something, and then you try to compensate, fill the gap, and progress. And now you are all living in an era where you need to harness the power of the smartphone. The app, the logbook, the auditing, the updates, and the registry could be a component of you. You every second you can go through it and make this tool very useful tool for you. You see a new drug which a cardiologist has put, and within second make it yours. See what's the half-life, what is the drug, what does it do, and everything that if you start doing it, you won't believe that in a few weeks time from now on, you will become such a learned anesthesiologist, which every cardiologist will say, oh, that anesthetist, oh, he's excellent. There is no need for me to go because his interpretation of ECG and echo is too good. So that is where we need to go. And so the final submission, we anesthesiologists are the true angels. We read a subject where we call it as the mother of modern medicine. We are the ones who are bestowed with the power to prevent death. And we make sure that we do this religiously for every single surgical patient. And each one of us should lead ourselves into this arena of becoming the best. And I would finish by quoting this book of Jim Collins, which I've quoted several times because it's such an useful book. Leaders display a paradoxical combination of personal humility and professional will, channeling their energy, drive, creativity, and discipline into something larger and more enduring than themselves. And this is what each of us have to do. If the future generation of anesthesiologists have to become perioperative physician, each one of us have to lead ourselves into this and make sure that the fruits are borne by the generations to come. So we need to provide excellent perioperative care. We need to become that supportive stick for every geriatric patient who wants, and that comfort that every geriatric patient wants. And the presence of an anesthesiologist, a versatile anesthesiologist, will make sure that he will never allow somebody to die when he is present inside the institution. Thank you so much for your patient hearing.
Thank you very much, sir. It was indeed a very warm, uh, absorbing, light throwing, and what qualities should I say? Absolute good topic for the postgraduates. Like Dr. Divetya sir too, as a moderator, to comment first about all this, the perioperative science with the anesthesiologist leading the front. Divetya sir.
So thank you, Dr. Balavenkat. So I think that is something that every anesthesiologist should hear, this kind of a talk. Very inspiring, very motivating. And I think the the sky is the limit as far as we can go. The question is, what do we need to do to get there? And I think the first and foremost thing is the will and the determination to do that. I think, and that's something which I think anyone who's been here today for this session will, I think, will resonate in everyone's minds for a long, long time. So, Dr. Bajwa, are we going to take some questions?
Yeah, sure, sir. Because this has to be an interactive session, and there are certain questions I like our screen coordinator, Dr. Sarita and Dr. Bhavani, to take over. The few questions were there. So first of the question, I think if they don't remember, I remember one questions. There was one question, how to admit the patient under us. So that was one of the things, that was the right questions when we are talking about taking over as a perioperative physicians. So I think it's difficult to take the patient under us as such because we are not directly doing our OPD or as emergency, but under ICU. When it comes to ICU, even with the open ICU, we are still have a patient under us. I like Dr. Balavenkat sir to develop on that particular
Yeah,
aspect.
that's an excellent question. And I just wanted to share what happens in my institution because this 24 years. So the surgeon, I mean, the patient gets admitted under an orthoplasty unit 1. Okay. So that's fine. But except for the surgery, the mobilization, the drain removal, everything else, like there are 3 anesthesia senior consultants. And what happens is there is an anesthetist in the ward posted all the time. And there is an anesthetist posted in the wards. In fact, all our blocks have an anesthetist who is posted there for 1 week. And they directly report it, like the unit system that is there in arthroplasty. Unit system is there in anesthesia also. So the arthroplasty fellow, registrar and the consultant says that which unit this belongs to. Is it Dr. Bala's unit, Dr. Shekhar's unit, Dr. Guru's unit? So unknowingly we have now kind of infringed. May not be technically that he was not admitted under you because it was seen in the OPD for a TKR by an orthopedic surgeon, but after that it becomes a part of you. And when you have anesthetized, it has been our responsibility that we follow through these patients throughout. So in fact, most of the patients know the anesthesiologist even if they do not know actually the surgeon. So, in other words, the more we start indulging in ourselves, more and more people started recognizing you. And in fact, the orthopedic surgeons, when they go for the rounds, you have this particular issue, I will ask our anesthesiologist to come and settle it. So this has become the norm now. And so the visibility is very, very high. So there is no issue. There is no need to be it on the paper. It can be in the minds of the surgeon and the mind of the patient and the attendant.
Yeah, that's actually in that way it should go. There was another point of thought about that. Hope the management should understand this thing. It's not about the management. I think first of all, we as a perioperative physician or as anesthesiologist, we have to please make everyone around us aware, all the surgical specialties, the medicine specialties, how important is our role in handling the patient, whether in the critical care, in the emergency, or in the operative area. Because your dedication, sincerity, and your skills and knowledge will definitely boost your status among your peers. It is not that some organization has to do something, it's an individual. How individually you are doing your job better, because even if you consider the surgeons or any orthopedicians, no five fingers are like. See, throughout the world, throughout the country, throughout any hospital, not every orthopedician will be a good orthopedic surgeon. So everybody is a different. So their importance is taken according to the skill of their surgery, and it's up to you. I think the anesthesiologists have to be best adapted in the communication because you're dealing with the critical care units where you almost face the last stage in any hospital. So you are facing the most critical care patient where you have to inform the bad news so many times. The communication skill, the communication with the surgical fraternity, with the medicine personnel. You should have a knowledge to such an extent. Anybody coming to you should know that you have adequate knowledge of the subject so that you make your importance. The management, I think, at many places may not be able to, like to hear from any particular specialty, whether it's an anesthesiologist or surgeon. It is up to us to make our presence felt. So I like to ask the thoughts of Divetya sir and Dr. Balavenkat sir regarding this particular point. It's a very pertinent point, sir. Divetya sir first.
Yeah, so this is a very important issue that you sort of raised, and in a multi-specialty hospital where you have physicians, you have specialists, like cardiologists, neurologists, nephrologists, uh, you got geriatricians, you can. So is what you're essentially asking is, can the anesthesiologist perform the role of a perioperative physician when there are so many other specialists around? And I think, again, like you mentioned, the anesthesiologist has to carve out that path for himself. You can't say that I only because the management is saying it will happen. No, I mean, ultimately, you have to not just even if the management tells that, okay, from tomorrow, Dr. Bajwa will be the perioperative physician, you still have to demonstrate and you still have to show that you can do the job. And you have to earn the respect and you have to earn uh, you have to earn that position that you seek. So ultimately you have to perform. If you cannot perform, it's perform or perish. So either you perform or you perish. So the bottom line is you need to perform. Now, how you perform, how you get things to do happen. And I think the anesthesiologist is very, very uniquely placed. Like Dr. Balavenkat mentioned early in his talk, we read a little bit about everything. We learn about all the diseases, all the conditions. No one knows surgery and surgeons probably as well as we do, right? So I think the combination of the knowledge of surgery, the knowledge of the perioperative changes, the intraoperative changes, plus the pathophysiology that's going on with the different conditions of patient, as I think we have that position. Now we have to mold ourselves into a leadership role, into the role of a perioperative physician. And of course, at the end of the day, we have to show results, and results will speak for themselves. But if you say, no, 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 I'm an anesthetist, how can I do something when there's a physician, there's an endocrinologist there are diabetologist there, how can I treat diabetes, how can I do it? Then you're finished. But first you have to say that, yes, I will do it, and then you can go ahead and do it. The only other question I wanted to ask Dr. Balavenkat is, do you think needs to be any change in the training pattern in our MD, or so that we are better equipped to perform as perioperative physicians when we set out, maybe not in an institution, but as a freelancer, or to this thing? Or do you think perioperative medicine should be a further super specialization after anesthesia, and where other faculties could also join in to become perioperative physicians?
So two questions. I will answer the first one. For example, ours is a single specialty hospital, so it became easy to establish this. But what if it is a multi-specialty hospital where there is a cardiologist, where there is a pulmonologist, where there is a hepatologist, where there is a gastroenterologist? Now the answer is simple. You write for an endocrine opinion. You write for a neurology opinion. Neurology is different, but I'm more importantly cardiorespiratory. So you ask for a cardiology opinion, pulmonology opinion, and the average time that it takes for a specialist pulmonologist to see a patient who was asked to be seen may be hours, but sometimes even a day. But if the anesthesiologist finds out the problem, documents it, records it, does the remedial measures for that, and also gets an additional opinion, I think no institution will say this is wrong, because appropriate treatment went to the patient at the earliest. That's point number one. Point number two, as far as the every single anesthesiology postgraduates is concerned, I think curriculum is already there. It is the way we look at it. Preoperative assessment of the cases that we are going to do, and even in private work, I think the most successful private practitioners with least complications are those who go and see, they get a list, even if it's an appendix, or appendix is usually semi-emergency, but for example, a hernia, even if it's an hernia, if they go and see the patient one day early, they detect so many new things that happen. They tell the surgeon, there is an issue. This is what I've noticed. This is what. Believe me, the surgeon will always call this anesthetist who identified a problem in possibly what was considered as a ASA grade 1 patient and prevented a possible complication. So every single anesthesiologist should do it. And I don't think it needs to be considered as a separate super specialization. The way we are growing, as I said, the gaps are the point of care ultrasound usage in the perioperative care, if that enhances, and if our knowledge about all the new technology that has come in becomes a part of us, every single MD, DNB anesthesiologist would be a perioperative physician. But to take the science forward, to do more research into that, I think it will be a great idea of the College of Indian Society of Anesthesiologists to present to the National Medical Commission on the need of an FNB perioperative medicine or DM perioperative medicine, as mentioned by Dr. Bajwa. I think that's a way forward in crystallizing our thoughts and making it a superpower.
Yeah, I think that's the way to go forward also, sir. And if you see about the peripheries, you rightly mentioned the point. Even if in ASA1, if an anesthesiologist is able to point out a particular pathology or a morbidity or a comorbidity, I think that raises the respect of that particular anesthesiologist. You may not be, given that favor, or sometimes you will refuse that case. But going forward, if something happens to that patient, the respect, goes like anything. And in the circle of the surgical specialty in the peripheries also, if you are doing a good work, you are seeing your patient well, rather than just seeing the patient on the table or doing PAC or just minimal PAC on the table. I think there's a difference in that. I think that is the attitudinal, difference we have to show when we really want to respect for ourselves, for our specialty. And there is another question regarding that how if you are referring to the super specialist or whatever called implication, medical legal implication. I think when you have got a super specialist in your own hospitals regarding certain pathologies or diseases which you are not well versed with, it's always better. But there are many diseases now which are being taught in the undergraduate and the postgraduate courses also of anesthesiology, where you always know the treatment. This is possible, and you have been treating with the ASA 1, 2, 3 cases, plus all the diseases you are reading in or studying in your postgraduate curriculum. I think the more you're confident, the only then you will grow. But I definitely, as Dr. Bala said in his speech, that around 5 to 10% in a single specialty hospital, only the need comes at 5 to 10% where they refer to the super specialist for particular opinions when they make the patient fit for a surgery. Your thought, Bala sir and Divetya sir, on this aspect?
Divatya sir?
So if I understand right, the query is about the medical legal implications, right?
Yeah.
Yeah. So this is something which you just cannot answer over here like this, because anyone can get sued for anything. Even a cardiologist can get sued, and for something that goes wrong. Now, so I don't know how to answer that. I mean, you are at least MBBS. You've done MD. You've done you've done so many things. So are you saying that only diabetologists can prescribe insulin? I mean, we are prescribing insulin left, right, and center in the intensive care unit, right? We are. Are you saying only cardiologists can prescribe antihypertensives? No, I think. But yes, but everyone is afraid of the law, and today if I say yes, you can do it, and you get sued, someone gets sued, they can sue me saying that I said you
Yeah.
can.
Yeah. Put your name.
Yeah. So I mean, so I think, and this is a fear, and unfortunately, there have been some court decisions which have been like that. Why did a neurosurgeon operate this spine case, and why did a why did an orthopod do this case and why not a neurosurgeon? I mean, so there are all these sorts of things which are there, and that is the whims and sometimes fancies of individual judges and whatever, I don't know. But yeah, so I mean, there is no law which says that you can't prescribe an antihypertensive. There is also no law which says you're the only person who can prescribe an antihypertensive. And ultimately, it's a matter of interpretation uh, uh, and how good. But I think if you've done the right thing and you've done it in the right way, if the process has been good, just because there's been an adverse outcome doesn't necessarily make you the guilty person.
Yeah, true. And
I
I
think
think that's
the
go ahead.
answer for this, according to me, is communication. And right from the word go, the face that sees the patient preoperatively when they start communicating, explaining to them the risks involved, the medications given, it is just the familiarity and the intent, the right intent. And when the attendant feels that there was no negligence that was happening in treating their parents or their relative, believe me that they don't go to the case. It doesn't go there. Only when they think that there was a negligence, when you were not being communicated, when your written informed consent was not obtained, if you have not taken them into confidence, then the suspicion comes. But otherwise, that's why I said in our 24 years, not a single anesthesiologist got sued for. We do average 28 to 30,000 cases per year, and nobody has sued us so far. I wish it doesn't happen, but I'm just saying that the faith and the communication are very crucial and important.
Yeah, I think that's if we are really well versed with the subject, our subject, we keep updating ourselves. I think that's the advantage of going to the conference, attending the workshops, where we at least have always update our knowledge, and we will be able to treat the patient accordingly. And I think the communication, the right communication, the consent, and all those things, if they are up to date, I think medical legal issues will come to the negligible. And going further to it, sir. Uh, if suppose this because one thing coming to my mind, Bala sir, taking it as a perioperative medicine, we have not seen the physicians or the cardiologist or nephrologist or neurologist coming into the operation theater. What are the dynamics of a perioperative period? Nobody knows about it. See,
Exactly.
so that's what I think when in the court of law also, if the people go to the court of law, our medical legal domains have to be redefined in those aspects also. Because what we have seen over the years, over the decades as a perioperative physician, these are the OPD physicians or the cold cases they have seen. They have seen them in a very, that way of life where the life is comfortable for them. But under stress, how they behave, we have never seen a cardiologist visiting the operation theater, only maybe sometime during emergency or somebody, if the acute renal failure occurs during perioperative period, nephrologist coming to that thing. So I think your thoughts on that also, sir.
No, it's perfectly right. I think, for example, we get a cardiac opinion. Cardiologists are extremely busy and they will come and see your patient for 2 minutes, for example. And I'll just give you an example. Here was a patient, 40 years old, BP was 240, 140. Cardiology opinion, he first put on one drug, second drug, third drug, fourth drug. It didn't budge, it didn't come down. You know why? The history was missed. I'm giving an example of how preoperative assessment and how important it is. So here that was missed, and this patient was on Largactil withdrawal, hypertension, and 4 drug added by the cardiologist. And the minute the mother came from the city 4 days later, she gave that usual drug that he takes, Largactil. Patient went into hypotension,
Hypotension.
and code blue announced, and he had to be resuscitated. So I'm kind of telling that we have been probably under the strong thought process that there is a medical legal issues against us. But I think as an organization, as Indian Society of Anesthesiologists, we will also take this up and probably in our endeavor uh, to discuss with both the National Board and the National Medical Commission in the opportunity that we get on this pertinent aspect of anesthesiologist as perioperative physician. And also happy to share that WHO has come with a new guideline because this year the WHO thinks that it is critical care that needs to be given in every part of the world. And now they say that every single hospital at least is blessed to have an anesthesiologist because of the C-section across Africa and across Southeast Asia. So they say that anesthesiologists should be empowered with more laws favorable to them. I think same thing, possibly we can quote that, and we can move our legal system also by properly representing this.
Yeah, that's really great, sir. And I think over the last 1 decade to 15 years, what anesthesiologists in our country is also feeling, I think we have progressed a lot. We have made a name for ourselves. I think whosoever attending this class or will be watching the YouTube later, they will come to know that they must be knowing that we have progressed in this stream like anything. I think the best people who are, and we are lucky that when the past presidents are watching this class today, Dr. Chakrarao was there, Dr. Kuchela Babu was also there. I request them to turn on their video and can also comment upon this issue, because the anesthesiology as a career previously, I think the 3 decades back, because we had all the new innovations, the drug discoveries in the last 2 decades, and which has led to a very safe perioperative period. And we are lucky because our seniors were giving the anesthesia in a very remote locations with all the previous type of whatever you call the equipment, the instrument, even for the ethers, where they used to do all that. The resource limitation at that time. So I think even this today's period, we have at least very lucky to have this thing. I request if Dr. Chakrarao sir and Dr. Kuchela Babu is there, they can also comment. I saw them previously. And then Dr. Divetya sir and Dr. Bala to continue. Sir, you can, Bala sir, you can continue from here. The decades, the advancements we have made, the respect we have gained over the last 2 decades, especially.
No, actually, I think, as I said, now the most of the surgeons are very, very sure about whom they want to have. And the more specialized it has become, the transplants, liver transplants, the organ transplants, and all this advancements have resulted in the anesthesiologist being given tremendous importance. Like, for example, now the neurosurgery with major tumors that are getting operated, so awake craniotomy, subcortical monitoring, major spine surgery, spinal cord monitoring. So all these technological advancement has allowed us to operate on critically ill patients with good results. And now this is very, very obvious, and most of the surgeons know it by heart. So I think we are in the right direction, and we will probably, as we move forward, we need to consider how to move government policies favoring us. So I think we will definitely work on it.
Yeah. So there were certain suggestions to start as a perioperative DM or a fellowship or FNB, whatever it is. I think we are still in that process. We are in a very infant stage of we calling as a perioperative physicians. I don't think so. Any other specialty will make a mark to be very much active in the operation theaters to be part of that perioperative courses where they will be able to do a DM or a FNB in this course. I think the only specialty remain is the anesthesiologist. And by time with that, there's a good suggestion calling anesthesiology. Previously, we call it anesthesiology, intensive care and pain medicine. Now adding another word, anesthesiology, intensive care, then perioperative physician and pain medicine. So we just keep on expanding our terminology. But I think that's a very good sign that we are progressing towards a society where our specialty is expanding its wing in almost all directions, out of operation theaters, inside operation theaters, and the trauma, emergency, pain. So many things are there. And for the house also, we just try to inform them that we have already pursuing this with the NMC and the education, the health ministry also about starting the DM course in the pain medicine very soon. So because and the board has agreed to that, sir, we have already put our case there, and the papers have already gone. we have put our president-elect as the nominee, because this was being pursued previously also, 2-3 years earlier. Now we are in a little bit faster mode to start DM as a pain medicine as a DM course. And I think if the time comes where we require perioperative medicine also to be started as a DM, so I think they will not be far enough. We will do all our efforts to start it if the need really arises. So, Dr. Divetya sir, your remarks for everything whatever discussed as a senior among all of us here, sir. Divetya sir. By the time.
Yeah, so nothing much to add. I think we leave the floor to Dr. Balavenkat to give his final sort of concluding remarks, except to say that, this has been an inspiring talk and a lot for us to think about, and definitely a lot for the future generations to look forward to. Thank you.
Thank you, sir. Achha, before I like to conclude with the Bala sir's speech and comments, I just like to felicitate our screen coordinators here because they did an extremely good job introducing the class. So, Dr. Bhavani, my screen is visible to you?
Yes, sir.
So, thank you, Dr. Bhavani, for being a screen coordinator. I think you people are very privileged to have such an eminent speaker on the dais and you being a part of this thing, this prestigious class. Thank you, Dr. Bhavani, for the screen coordinator.
Thank you, sir. Thank you for the opportunity.
And similarly for Dr. Sarita, you being an equally good participant and helping us in this conduct of this class. Thank you very much for being the screen coordinators.
Thank you so much.
Also thank our class coordinators, Dr. Madhuri, Dr. Nishant, and Dr. Ritima. They are always there to help us coordinate with the screen coordinators to conduct this in a very technically smooth way. The classes are recorded and everybody can watch these classes later on at YouTube at ISNHQ. I think that should be known to everyone now. These classes are, can be seen later, can be streamed later at YouTube at ISNHQ. Now, final concluding remarks by Balavenkat sir.
Thank you so much, Dr. Divatya sir, Dr. Bajwa, all the respected senior anesthesiologists, past presidents, GC members, professors, additional professors, and postgraduates who attended this session. And I think we need to introspect. We need to find our gaps. We need to strengthen it. And each one of us have to make sure that every passing day we become better version of ourselves, because when we become a better version of ourselves, it results in one life being saved, one life having less pain, more comfort. And that's why our meetings are so crucial and important. Our conferences are so important. Our sessions are so important, because if we don't attend the sessions and gain what is being spoken in the session, we have lost an opportunity to save a life. And that is why our conferences have to be taken more seriously. And networking can happen in the evening, but the daytime, I would want it and request. We are really earnestly trying on behalf of our academic chair, Dr. Divatya, Dr. Bajwa, the scientific committee, local organizing committee in Raipur. We are planning it so much that every minute that is spent by both the delegate and the faculty is resourceful, enriching, impactful, preventing some life being saved somewhere in the next year to come. This is what we aspire to, and we request all of us. I mean, it's a joint, it's a teamwork, and we need to put this country on a very high pedestal because of our contributions. And I'm so happy that I could be a part of this PG session. And Dr. Bajwa, thank you so much for this opportunity. And also, I thoroughly enjoyed the way we started with Saraswati Vandana. It just produced the divinity inside and, the perfect start for a teaching program. And thank you so much.
Thank you, sir. I think that's all the efforts of our team, which names are well taken, Dr. Madhuri, Dr. Nishant, Dr. Ridhima. So this is our team. We are doing always like that. Every class starts with the Saraswati Vandana only, sir.
Yeah, my sincere thanks to Madhuri, Dr. Ridhima and Dr. Nishant. Sincere thanks for your great work that you're doing.
Yeah. So I think it was a wonderful class, inspiring, motivational, eye-openers, as well as very brainstorming. So till next Monday, it was you can always watch this class again on the YouTube. Till next Monday, we have to say goodbye, and we always end the class by saying "Long live ISA."
Long live
Long live
ISA, and thank
ISA.
you so much.